This is Dr. Andrew Young at USC, and in this video we're going to talk about the management of secondary arthritis that develops after Perthes disease. Perthes disease is a childhood condition in which the blood supply to the ball of the hip joint, femoral head, is temporarily interrupted, and without enough blood, the bone becomes weak and may flatten or even collapse. And although the body eventually repairs the bone, the femoral head often does not return to its original normal round shape. Now, fortunately, children are wonderfully resilient. Many regain excellent function, but the hip itself grows differently from that point forward. Some children recover with a nearly round hip, but many others are left with a misshapen ball and socket joint. And these structural differences may not cause a lot of trouble in youth, but they often set the stage for arthritic change later in life. When arthritis develops after Perthes, we call it a secondary arthritis because it is directly related to the structural consequences of the childhood conditions. This is very different from a primary arthritis, which occurs without any specific underlying anatomic cause. In Perthes, the irregular shape of the femoral head grinds unevenly against the socket, and this accelerates the breakdown of cartilage and arthritic change. And as the cartilage wears away, the joint eventually becomes bone-on-bone arthritic. And over time, this process leads to stiffness, pain, and functional limitations, which we recognize as an end-stage arthritis. Several classic or hallmark changes we see in adults who had Perthes disease as a child. The femoral head is no longer round. It had been flattened, enlarged, or even becomes mushroom-shaped. And it no longer fits smoothly into the acetabulum. And this mismatch is what causes the abnormally high joint forces, which lead to premature arthritic change. The femoral neck itself is also changed. The femoral neck is often shorter, and the greater trochanter will sit higher than the center of the femoral head. And this alters the mechanics of the hip and could potentially weaken the leverage of the abductor muscles. On the socket side, because of the flattened head, we'll often see a residual dysplasia. So instead of curving back down to form a deep concavity, the acetabulum is shallow and slopes upward. And finally, many patients will have a leg length discrepancy as a result of the growth disturbances. And taken together, these changes explain why the hip wears out prematurely and why reconstruction is especially challenging in secondary arthritic change. So the prior images were our diagnostic images when we understand what is happening and how the patient developed arthritic change. These radiographs are different. These are our calibration radiographs, and these are taken while the patient is under anesthesia and allow us to precisely position the patient. So here we have the neutral pelvis. We can see the pubis and the coccyx are lined up. We have symmetric obturator foramina, and the legs are in the same abduction and rotation. But we can see here we have a shallow acetabulum, we have a misshapen femoral head, a shortened neck, and associated leg length discrepancy. And we can start quantifying the degree of deformity because we have a neutral pelvis, neutral leg position, and a calibrated image. Once we have this calibrated image, our first task will be to restore the center of rotation in the acetabulum. So we'll medialize up to Kohler's line, and then we'll arrange the height so that it is at the superior rim of the pre-existing shell. And then this reestablishes the concavity of the acetabulum. We'll then plan for our femoral component so that we have an appropriate fit and fill. And then we'll plan the height of this femoral component so that this distance recorrects our pre-existing leg length deformity. And then throughout the case, we will use fluoroscopic navigation to check our progress in real time. And I find that this has been far more helpful than robotic surgery because it allows me to see both the femoral side as well as the acetabular side in real time and constantly comparing the symmetry to the opposite side. These images are then run through software that gives us quantitative measurements of leg length and offset. And so we'll drop a vertical line from the sacrum to the pubis. We'll draw a horizontal line across the base of the teardrops, and then we'll drop verticals in the neutral position on the right side and compare it to the left side. And here we see that we have 20 millimeters on the non-operative side and now 20 millimeters of hip length on the operative side. So we've been able to restore the center of rotation. We've have a stable stem, and then we've chosen a head neck geometry that allows us to restore the hip length so that it is symmetric to the opposite side. And when the reconstruction is complete, the postoperative films tell the story. We can see the acetabulum now has a restored concavity, and the hip center of rotation is back where it belongs. The femur has been reconstructed with a press-fit collared stem with a dual taper design that provides stability. Leg length or hip length and offset have been restored to allow the patients to regain proper biomechanics. So this is how we take care of Perthes. It's often a challenging condition, and it is made far more predictable with the use of enabling technology. Thank you.